Welcome to this recording of the Global Adult Guideline, What Families Need to Know, brought to you by Down Syndrome Association of Northeast Ohio with Dr. Carl Tyler.
So good evening. I'm Laura Sifrabine. I'm the Medical Outreach Director for DeSanio. I am a pediatrician who spent 25 years in primary care, and now I'm the Medical Outreach Director. And I have an adult son, Christopher, who has Down syndrome. I'd like to welcome you all to this presentation on the Global Down Syndrome Foundation's medical care guidelines for adults with Down syndrome. And I'd like to welcome Dr. Carl Tyler tonight and just thank him so much for coming. Dr. Tyler is a family medicine physician, fellowship trained researcher, and professor of family and community medicine at Cleveland Clinic Lerner College of Medicine, Case Western Reserve University School of Medicine.
That's why I wanted to.
I would just like to ask everybody to mute themselves until the question and answer session. Thank you. He received postgraduate training in psychiatry at University of California, Irvine, and family medicine at the Cleveland Clinic Fairview Hospital. And then he completed a fellowship with a master's degree in academic family medicine and an NIH-sponsored 3-year fellowship in practice-based research design and methodology at both at Case Western Reserve University. Dr. Tyler has a certificate of added qualifications in geriatrics and is a certified medical director in long-term care. He is fellowship trained researcher and he assists residents, physicians, and faculty in conducting their scholarly work. Since 2013, he has directed the Developmental Disabilities Practice-Based Research Network, a community-based participatory network that brings together stakeholders across multiple domains of the developmental disabilities field. And he is a national leader in healthcare for people with intellectual disabilities and current president of the American Academy of Developmental Medicine and Dentistry. And I'm very happy to say DeSanio is very lucky to have Dr. Tyler as a member of our own medical advisory board. And he was an author of the Global Down Syndrome Foundation Medical Care Guidelines. And we're so happy to have him here today. So welcome everybody and welcome Dr. Tyler. I'll turn it over to you now.
Thank you very much. And so appreciative of DeSanio's involvement in our local developmental disabilities practice-based research network, and appreciate Debbie Picker's long-term participation in our network, and Dr. Sifrabine's more recent joining of our research network. So thank you all. So thank you for, again, I appreciate DeSanio, previously known as Upside of Downs, long-term participation and service to our local community. And so always happy to help out in any way you see fit. So thank you for the invitation. So I also want to thank Global Down Syndrome Foundation, who orchestrated the compilation of these guidelines. This took a lot of work, and this took a number of years to do. And so I'm just so pleased that we're at the stage where we can disseminate some of these guidelines about medical care. And there's more to come, and we'll be talking about that. In terms of what I want to present, we're going to provide an overview of these guidelines, and I'm going to present a little more detailed information about some of the sections that I was involved personally with writing. And then we'll let you know about what languages the guidelines have been translated into, and what are some topical areas that we plan to tackle in the near future, and then provide some time for questions and answers. So what was exciting is that the Journal of the American Medical Association saw fit to publish our initial set of guidelines. And I think that says a whole bunch about where we've come in terms of the medical literature, seeing the importance of providing and disseminating new knowledge about people with developmental disabilities, and the importance of that work. So we're very proud that these guidelines were seen as important enough, and the methodology behind their development rigorous enough that you know, they were accepted for publication in one of the premier medical journals. You know, and that helps us know that many people are reading about these guidelines. Physicians in different specialties, health professionals of all stripes know about these. Again, my hats off to Global Down Syndrome Foundation for the vision to create these and to support the work to do them well. So the guidelines cover the 9 topics you see listed, and you know, the writing group spent a long time deciding what would be the initial topics we would tackle, and part of that decision was based on what group members thought were important, and what were topics for which we had some information. It's important for family members to know that this is the first iteration, that there are many other health topics that deserve attention. And so this is not exhaustive, and this is, you know, ongoing work. The other thing I think that's important for families to know when they hear about these guidelines and they receive literature about the guidelines is that this was an attempt to summarize research that provided some background knowledge for us to make recommendations. And so, you know, much of our work behind the scenes with these guidelines was discussion about where we need to do additional research. And so in some ways, these guidelines are kind of limited because they're not, you know, necessarily everything that's done presently in clinical practice, or these guidelines don't necessarily kind of support what you and your doctors have decided might apply to your family member. They're more, what does the evidence support regarding clinical care? And so I think I don't want people to kind of attend the seminar and think, well, gee, my doctor's not advising this or recommending this, or they're recommending more, because there may be more to the story that's individual and individualized and tailored to you or your family member. But these guidelines are primarily a summary of the research to date on these topics and what does the available knowledge tell us. So I think part of the important kind of vision of Global Down Syndrome Foundation is that the guidelines aren't just going to be academic work published in medical journals, but they're going to be translated into practical knowledge that community-based physicians and family members and individuals can utilize and apply to their own healthcare. And so to that extent, the guidelines are kind of summarized in text that's plain language, that's clear to understand. And that's going to be the kind of structure of future guidelines as well. So we have from the talk, which I assume Dr. Sifrabin will be able to disseminate to you all, you can get a free download of the family-friendly global adult guideline by entering the link on the web.
And DysAudio did mail a printed copy to all families who had an adult with Down syndrome earlier for Down Syndrome Awareness Month.
Wonderful. Always on the ball. Good for you. So the first topic I wanted to just briefly discuss is the topic of atlantoaxial instability. The guidelines do address the following, that routine X-rays of the neck with the intention of screening for risk of spinal cord injury in people who have no symptoms are not recommended. Instead, what is recommended is that all adults with Down syndrome should be evaluated for signs and symptoms of any adverse process involving the neck, and then there should be a targeted physical examination maneuvers to look for signs of compression of the spinal cord in the neck. So this is a change in practice for what many of you maybe have experienced in the past, where at a time, different medical organizations did recommend routinely, even if people were having no symptoms and no physical signs of any kind of spinal cord compression, they were recommended to have X-rays of the neck. And this is no longer recommended under the Global Down Syndrome Guidelines. So just to review what is atlantoaxial instability, one of the features of Down syndrome is a laxity in ligaments and other connective tissues. So connective tissues in people with Down syndrome tend not to be as strong as people without Down syndrome. That renders people with Down syndrome to joint sprains, ankle sprains, for example, dislocations, for example, dislocation of the kneecap, the patella, and then also this phenomenon of atlantoaxial instability. So atlantoaxial instability refers to anatomic structures that are at the very top of the neck. So the first vertebra, as you see in this picture, is called the atlas. The second vertebra refers to the or the axis, and the joint in between is the atlantoaxial joint. And so normally ligaments keep these two top cervical vertebrae in proper alignment. And in people with Down syndrome, sometimes there could be abnormal laxity of the connective tissues, and these two vertebrae assume unstable position in relation to each other. And what can happen is that the vertebra can compress or put pressure on the spinal cord. Now, a lot of individuals can have atlantoaxial instability, and yet they never develop actual damage or injury to the spinal cord. So most people are without symptoms. If people do have symptoms, what they may report is neck pain or restricted movements of the neck, or they may assume abnormal posturing of the neck, like to one side. And then, rarely the atlantoaxial instability can be so severe that it causes very serious damage to the spinal cord and can cause paralysis and can cause other neurologically based symptoms like new onset incontinence, weakness of the arms or legs. And so the global Down syndrome guidelines attempted to examine the literature, the research around the question, should adults with Down syndrome be routinely screened for atlantoaxial instability? And what was determined on the basis of existing literature is that there is not any value to using X-rays to screen for risk of spinal cord injury. However, there was evidence to suggest the value of reviewing signs and symptoms of atlantoaxial instability and associated spinal cord compressive symptoms. And there was literature to indicate the value of doing a targeted history and physical examination to look for abnormalities that reflect pressure on the spinal cord. So in the table you see on the left side of the slide, these are some of the symptoms and signs that physicians need to look for in screening people for atlantoaxial instability and associated spinal cord compression. So at the bare minimum, what you should see your physician do is check for reflexes, is to ask a bank of questions relating to strength in the lower extremities, and question whether there's new onset of incontinence, and then examination to make sure that reflexes are not brisk or hyper reflexive, they're not excessively strong. People with Down syndrome in general have low motor tone, as you know, and they tend to have kind of weaker, less responsive, deep-tended reflexes. So it's distinctly unusual when reflexes are brisk. Another sign that your physician should check is something called ankle clonus, and that's when the physician allows the person to let their ankle and foot go limp, and then suddenly push their foot upwards towards their shin. And ankle clonus is the phenomenon where the foot will involuntarily move up and down. So that's called ankle clonus. And so that's another kind of core sign the physician should be looking for as a screen for spinal cord compression. The next topic is osteoporosis, and this is one that I was personally involved with as part of the writing team to develop. Fairly, quite a number of decades ago, actually, I did some research in this area myself locally. It was noted that people with Down syndrome seem to have low bone mineral density. So there's various ways of measuring the density of bone in order to understand bone health. And one is through the use of a DEXA scan, dual X-ray absorptiometry. And typically in general clinical practice, what's measured are DEXA readings of the spine and of the hip to determine whether there's lower than average bone mineral density of those two areas, because with aging, what causes a lot of harm and is even associated with death is first and foremost hip fracture, and then what's associated with chronic pain and disability is fracture in the spine. So in clinical practice, usually DEXA scans are conducted on the hip and spine of aging individuals. And because women tend to have lower peak bone mineral density, and they particularly lose a lot of bone mineral density during the menopausal years, early menopausal years, the first guidelines were developed to recommend kind of routine DEXA measurement of bone mineral density in women age 65 and at earlier ages if they had risk factors. So researchers a number of decades ago observed that individuals with Down syndrome who had DEXA scans done were noted to have, even at young adult ages, low bone mineral densities. And so then there was a lot of confusion in clinical practice about, well, should people with Down syndrome get DEXA scans? Should they get them at an earlier age than the 65 years recommended for women without Down syndrome? Should people with Down syndrome with low bone mineral density values be given osteoporosis drugs to try to strengthen the bone? So a lot of questions came out of this whole issue of low bone mineral density observed in people with Down syndrome. And you know what's important with any discussion about bone mineral density and DEXA scan values is, does it predict likelihood of fragility fractures? And you know, so osteoporosis can be defined as a certain value bone mineral density. So sometimes you hear osteoporosis defined simply as that, but in other contexts, osteoporosis is defined definitively as fragility fracture, as someone fracturing a bone under circumstances in which the biomechanical forces in most people wouldn't fracture the bone. And that's what we really want to know is, does bone mineral density values predict fracture risk, specifically in people with Down syndrome? And are the drugs that we commonly use in people with Down syndrome to improve bone health effective in people with Down syndrome? And are the side effects of those drugs the same, less, or more? So this generated a whole bunch of questions for our team. So one of the areas that have been investigated is how can we modify bone mineral density testing to make it more applicable to people with Down syndrome? Are some of the lower values for bone mineral density observed in people with Down syndrome just relate to the fact that they're shorter stature? And so researchers have attempted to modify bone mineral density testing by using such adjustments as something called volumetric bone density that adjusts for the size of bone. So that's still an area of research. How can we, what are the types of measurements that are most predictive of fracture risk in people with Down syndrome? You see here what a DEXA scan often appears like. So for someone to get a DEXA scan where they're focusing on the lower spine, the lumbar spine, and the hip, people may be positioned with their hips and knees, as you see in that picture on the left. So what the literature tells us to date is that at the present time, we do not have sufficient evidence to recommend for or against applying established osteoporosis screening guidelines that have been developed for the general population. This includes, we don't have evidence to really guide whether or not people with Down syndrome should undergo DEXA scans, and if so, at what age. It's also relevant to talk about the fact that we do have fracture risk equations that have been developed that can incorporate data like bone mineral density to inform a 10-year fracture risk. Because to date, there have not been studies looking at fracture rates and fracture risk data. No such kind of analogous fracture risk estimate equation has been developed to date specifically for people with Down syndrome. So there's not sufficient evidence to recommend using fracture risk estimate equations that we use for the general population for people with Down syndrome. And so what we recommended is a shared decision-making approach. And, shared decision-making kind of should be how things work for most medical decisions, where the decision is sharing information between patient and physician, and kind of together coming up with a final decision, rather than heavily weighing kind of what the physician recommends. Because at this point in time, we don't have the data to recommend a specific strategy for screening. One worry is that if you utilize the present fracture risk scoring systems or equations that are applied to people without without Down syndrome, that if they're applied to people with Down syndrome, you're going to identify people with Down syndrome almost always at being at high risk for osteoporotic fracture, and it would almost always lead to a recommendation for a drug in the family of bisphosphonates. So sorry for the misspelling. That should be bisphosphonates, BIS phosphonate, not biophosphate. So sorry about that. One thing we can recommend, and this is similar to the population of individuals without Down syndrome, is that if an adult with Down syndrome does sustain a fragility fracture, they should be evaluated for medical conditions that are associated with osteoporosis. So if someone has sustained a fragility fracture, that is a fracture that would normally not have occurred in someone with healthy bones, then the physician should do a number of blood tests essentially to look for medical conditions that can affect bone mineral density. So you see listed some of the medical conditions that should be checked for, and that includes thyroid disease, celiac disease, vitamin D deficiency, which is very common in the general population without Down syndrome, as well as people with Down syndrome, a glandular condition called hyperparathyroidism, and then they should also, their medication regimen should also be carefully evaluated for drugs that have an adverse effect on bone health. So a lot of those drugs include certain seizure medicines, such as Dilantin or phenobarbital, which have an adverse impact on bone health and are associated with increased risk for fragility fractures. So the guidelines also recommend to follow fracture prevention measures such as optimum calcium intake, and to improve bone health. It's recommended that calcium be primarily obtained not through supplements, but through diet, through foods, through dairy products. And we know that taking calcium supplements can actually, especially at high doses, cause harm, increased risk for kidney stones, whereas taking consuming foods and beverages that are high in calcium naturally actually lowers your risk of stones. Fall prevention is important, and some individuals with Down syndrome may have poor neurologic function in the realm of what's called proprioception. Proprioception is the neurologic ability to kind of feel where your limbs are in space and how your body is moving. And so there's some evidence that to suggest that people with Down syndrome may have impaired proprioception. And so that may be one of the reasons why some may be prone to falls. Another fall prevention measure is optimizing vision. So we know that some people with Down syndrome can develop cataracts at, well, they can be born with cataracts, but then They can also develop cataracts in earlier life than what's normally observed. So in people in their 30s and 40s can develop the cataracts that are typically seen in 60s and 70s and 80s. So, routine monitoring of eye health is important. And then weightlifting. So resistance exercise can improve bone mineral density. So these are all preventive measures that we can say should be promoted. So want to mention the guidelines relating to thyroid disease screening. So on the basis of literature review, the guideline authors recommended that adults with Down syndrome should be screened for hypothyroidism under active thyroid function by blood test every 1 to 2 years, beginning at age 21. And the basis for this is that hypothyroidism, the prevalence of hypothyroidism in adults with Down syndrome is very high, and some studies have suggested that young adults may have prevalence rates as high as 40%, and in adults with Down syndrome over 30, maybe as high as 50%. Part of the difficulty with recognizing thyroid disease is that many of the core features that are common to people without thyroid disease are already present in people with Down syndrome, such as dry skin and constipation. Clinicians, family members may misattribute true symptoms of thyroid disease to what is just considered a feature common to people with Down syndrome. So it's hard to recognize thyroid disease emerging in many people with Down syndrome. And that's why you have to rely on a blood test rather than relying on signs and symptoms, which is how we screen for a lot of conditions medically. It is important to note that treatment of hypothyroidism may improve cognitive function and may improve weight management. Essentially all the cells in the body require thyroid hormone for optimum functioning. So it has total body effects when you have insufficient thyroid hormone or excessive thyroid hormone. So let's move on to another topic that the first set of guidelines addressed, which was celiac disease. So I know a lot of families are pretty savvy about celiac disease, but just to review, celiac disease is an allergy to a component of many grains called gluten, and it's a protein that's found in some grains containing wheat, rye, or barley. The general population prevalence of celiac disease is about 1%. In some studies of people with Down syndrome, the prevalence rates were as high as 10%. So 10 times the general population rate. There can be symptoms of celiac disease that are related to the gastrointestinal tract, such as bloating or diarrhea, or they can be there can be symptoms related outside the gastrointestinal tract, such as the skin, such as rashes. And I think what's particularly important is, celiac disease can cause behavioral disturbances, can cause people to be angry, to be irritable, have poor sleep, and so it can be hard to detect when the predominant symptoms are not related to the gastrointestinal tract, but related either behaviorally or to other organ systems. We know that there's a genetic predisposition to celiac disease, so it can run in certain families. So it is relevant to know if celiac disease already runs in a person's family, and then they also have Down syndrome. Symptoms can also be related to secondary vitamin or mineral deficiencies that occur as a result of untreated, more long-standing celiac disease. So people who have untreated celiac disease can become iron deficient. They can become deficient in calcium, in vitamin B12, in folate, and then they can lose protein when large portions of the intestinal tract are affected. And so people with untreated celiac disease can lose massive amounts of weight and just have a general problem with malnutrition involving many micronutrients. So in diagnosing a celiac disease, we have some very helpful initial screening blood tests. So they've been kind of a series of several generations of blood tests that have been developed over the years to help diagnose celiac disease. Initially, there were what are called anti-gliadin antibodies. Then the kind of second generation were something called anti-endomysial antibodies. And maybe some of your family members had those blood tests. But the latest generation of antibody tests relating to celiac disease are called the anti-tissue transglutaminase antibodies. When they are elevated in kind of high amounts, or what are called titers, it is highly suggestive of celiac disease. And 99% of people with celiac disease will have positive tissue transglutaminase levels, antibody levels. However, definitive diagnosis is based on a small bowel biopsy, and so that requires scope down the throat, through the esophagus and stomach into the first part of the small intestine. It is important if you're seeking evaluation for family members in whom you suspect the possibility of celiac disease, you should not restrict gluten-containing foods and then do antibody testing, because cessation of gluten food ingestion can cause the antibody levels to drop, and then you can mistakenly think that someone doesn't have celiac disease because their antibody levels are normal if you've been restricting gluten-containing foods for a number of weeks to months prior to the blood draw. You see here a list of gluten-free grains that people with celiac disease can ingest versus those kind of flours and grains that contain gluten that are problematic. So what's next for the global adult guidelines? The next 5 topic areas we're going to be looking at, and I actually have a phone call this week with fellow authors, are sleep apnea, solid tumor cancers, leukemias, physical fitness, and vision and eye health. Part of the work of Global Down Syndrome Foundation includes checklists and toolkits to help people kind of implement the guidelines, and for families and clinicians to better understand the guidelines. So for celiac disease, for example, you see on the right this checklist. So those are useful in terms of implementation and dissemination. And toolkits relating to behavioral health and dementia are forthcoming. Global Down Syndrome Foundation has been also working hard to translate the guidelines into languages other than English. And so now you see Spanish and Japanese, and then you see a list of other languages that they're preparing to translate. So here are some references that you can click and link to. And thank you. Thank you for your time and interest, and thank you for your support of Global Down Syndrome Foundation and the work we're doing.
Thank you so much, Dr. Tyler. That was great. So full of information.